Scooching close to you, Bruce. All right, well, why don't we go ahead and get started. I want to thank those of you who have joined us here this morning, an opportunity to talk about the Affordable Care Act and what's going on within the state of Alaska as it relates to healthcare access, costs, and the things that are on Alaskans' mind. Again, those of you that are here, thank you. We are streaming this live on our website so that people around the state can hear what's going on as well. This has generated a fair amount of interest as people anticipate the implementation of the Affordable Health Care Act. What I had hoped to gain this morning from our invited guests was a little bit of a discussion in terms of what this healthcare law may bring to different sectors, whether it's the healthcare sector, whether it's small businesses, whether it is those that are out in the state, individuals. And so my hope with this relatively informal format is that we can actually have a bit of a dialogue. I think it's clear as I've traveled around the state, Alaskans have great concerns about healthcare access, and the costs of healthcare. We passed a $2.6 trillion healthcare law. This is going to impact virtually every Alaskan, and I believe make some long-term changes to the way that healthcare is delivered here in this country. In my office, since the healthcare debate began back in 2009, we have received well over 20,000 emails, letters, phone calls on the subject. We hear a lot from business owners about how the law will impact them. After the passage of the Affordable Care Act, it was about 72% of small business owners reported to the U.S. Chamber of Commerce that they had concerns that implementation of the law would make it harder for their businesses to hire. Now, I do think it is important that we recognize that there are some good things that are contained within this law. I, for one, feel it's exceptionally important that we have provided for coverage for those with pre-existing conditions. I think that is absolutely necessary. I think it's also very good that we have made allowances for younger adults up to the age of 26 to stay on their parents' plan. I think Alaskans have asked for that, Americans have asked for that, and that's continuing. I have also been very active in advancing the Indian Health Care Reauthorization Act, which is contained within the law itself. I think that's good, it's important, and I want to make sure that those provisions remain in place. But the big problem that we're facing with so much of this is it's all baked into one cake, and you can't just kind of take the ingredients out of the cake. You really need to look critically at how we can remake it, how we can start it over. So as we discuss the issues and concerns that I'm hearing, particularly from small businesses, the number one concern seems to be the employer mandate, the requirement that any employer who has in excess of 50 or more employees, that they have to provide a certain level of coverage to their employees, or they pay penalties in the range of $2,000 to $3,000. This is, of course, the ruling that the Supreme Court came down with in June, determining that, in fact, these penalties are constitutional because they have construed them as a tax. In Alaska, this employer mandate will hit 233 businesses, so we've identified who falls into that. But I think it's important to recognize that this is just one of the taxes that we're looking at. There's a lot of provisions contained within the Act that add to additional costs. There was a company in Indiana last month, Cook Medical. They specialize in medical devices and specialize in surgery, obstetrics, and gynecology. They're scrapping their plans for opening 5 new plants because of the tax on medical devices, whether it's for dental implants or knee or joint replacements. This is a 2.3% tax that will will go directly to medical devices. So as we think about the taxes that do come into play and the impact that that will have on businesses, it essentially comes down to a new cost of doing business, and unfortunately a cost that is very likely to be passed on to those of us in Alaska, whether it's the cost of food, whether it's lumber, whether it's clothing. We've already seen signs from national businesses that are predicting higher costs from the expenses, and that's part of the conversations that I want to have today, is how is this going to impact us here in Alaska? On an individual basis, I think folks are wondering, what is this going to mean to me personally, to my family? Are my health care costs going up? There's three taxes that I think are somewhat interesting to focus on here in Alaska, because Alaska is a high-cost growth state. We all know that our shipping costs, our fuel, our food costs, our health care costs, these are all among the highest in the nation, so our incomes then are higher. And because of that, you've got three healthcare taxes that are not indexed for high-cost growth states. So that's going to impact us here in Alaska more than in other parts of the country. There's a new 3.8% tax on investment income for families and businesses that earn over $250,000. This tax goes into effect in January. And this is also in addition to the other taxes that you're paying on cap gains, on interest dividends, certain rental income, as well as on non-primary residence income. And you'll keep in mind that just last month there was a measure that passed the Senate that increased the base tax on cap gains from 15% to 20%. You've also got a 0.9% increase in Medicare payroll taxes, bringing that total to a 2.34% tax on salaries and wages. And then there's another tax, which I think, there hasn't been a lot of discussion about it in the state right now, but I think it's something that is going to hit us disproportionately. And this is what is being referred to as the capital tax. It's expected to hit about half of the Alaskan residents. And this is a 40% tax on your health care benefits. And when I say it's going to hit us disproportionately, it's because our insurance premiums here in this state are higher, or among the highest in the nation. In fact, Alaska has the highest premiums. You can see up there on the slide. Alaska has the highest premiums for individuals with employer-based health coverage. And this is according to the Agency for Healthcare Research and Quality. Our employer-based plans, our family plans, are the 8th most expensive in the state. So we're already up there in the very, very highest bracket. So for over half the state then, individuals, families that are on what is termed these Cadillac plans, that means about $1,500 more per person and over $5,000 per family plan when it kicks in. These are estimates that are coming to us from Primera. So the new 40% tax is going to be assessed on all of the health care plans that are valued at $10,200 on an individual plan, $27,500 for a family plan. So again, this is going to hit about 50% of Alaskans. You look at the lower 48 and where it's going to hit individuals there, families there, the estimate is there will be about 10 to perhaps 15% of the rest of the country that will be impacted by it. So again, it's because of Alaska's high cost areas. Now, I said at the outset, there are some good things within the Health Care Act. There are some good benefits for Alaska. But I think it's important to recognize that those good things are going to cost. And there is some sticker shock that I think is associated. Alaska is estimated to get $381 million in federal support for refundable tax credits. This will go to help with the cost-sharing requirements for individuals. This means that for those that are up to 400% of poverty, they will receive some form of federal support. Now, there's an estimated 50,000 exchange enrollees, so about 64% of Alaskans would receive some level of federal premium support. This is according to Mark Foster's study. My concern, though, is that in order to in order to provide this level of support to Alaskans, the 381 million, what we have to do is we've got to tax individuals, we've got to tax employers. We're cutting $528 billion from Medicare. We're taxing medical devices. We're imposing additional taxes in order to pay for these subsidies. And again, keep in mind, we've got a $16 trillion debt. So we are effectively taxing us to pay for the higher cost of insurance. What we haven't done is reduce the cost of that insurance or reduce the cost of health care, which is essentially what I think people had hoped and believed that we would be doing with passage of a health care bill. And I mentioned these taxes. I've singled them out because I think that they will have greater impact to us in Alaska than some of the other provisions in the Affordable Care Act. But I think it will help spur the discussion this morning. Those that I've invited to join with me today, I'd like to introduce and move to the dialogue. Dr. Bruce Kiesling here is the Medical Director of Primary Care Associates. This is the largest primary care practice here in the state. It's been named one of America's top family doctors by Consumers Research Council of America. Next to him, we have Mr. Michael Draghi. Michael is the President-elect of the Alaska Association of Realtors, the Director of the National Association of Realtors, and co-owner and General Manager of Century 21 North Homes Realty. And next to Michael is Mr. Skip Winfrey. He's the President of 10th and M Seafoods. And those of us here in South Central know and love 10th and M because you keep our fish fresh and allow us to be eating good seafood throughout the year. Skip employs 120 people, I understand. That number goes up and down depending on whether it's summer or whether it's winter. But here to talk about it from the small business perspective. So, gentlemen, I thank you for taking the time this morning to talk with us and just share a little bit about some of the issues that we may be facing here in Alaska and how it impacts you. Dr. Kiesling, I'll go ahead and start off with you. I understand that within the practice you've got about 40 employees or thereabouts. But rather than talk about how this might impact you as a business, I'd like to have your understanding in terms of what implementation of this law is going to mean to access for our Medicare patients here in the state of Alaska. The Affordable Care Act, as I mentioned, includes over $528 billion in cuts to the Medicare program. And these cuts include $135 billion to hospitals, roughly $15 billion from nursing homes, $40 billion from home health agencies, nearly $7 billion from hospices, and $550 million in reimbursement for power wheelchairs. So if you can kind of start off the conversation by giving me a little bit of insight in terms of how you believe we will see impacts on those that are Medicare eligible.
I have to confess, thank you, Senator, and thank you all for being interested in this topic. I have to confess that she gave me that question that she probably was going to ask me. So
you're prepared.
Well, the answer is it's going to be as Mr. Whitekeys, and his skit. It's bad, partly bad, and it's horrific. I don't know if you read the Wall Street Journal like most geezers my age. I get a little insomniac, and my Kindle downloads Wall Street Journal at 1 o'clock in the morning, so I read it. And did you see that we got this new industry in medicine that's going to explode, and it's going to be concierge medicine. It's going to explode because the panels that are going to be required under the Obama Act will require a physician to have 2,500 to 3,000 patients minimum in order to meet the requirements under the metrics of prevention and other things. So I want you to know that the MD VIP, one of the bigger concierge, they've flown up their VIPs and have lobbied me now for the last year and a half. Dr. Kiesling, you're well regarded, you got a big group of patients, be a cakewalk for you to just segue you into concierge medicine. If I were to do that, then I have to tell the patients that I see, that, you know, you'll have to buy into this concierge program, and the rest of them I can't see. It will go from a panel of 2,500, for instance, in this new industry that's exploding, a panel of 2,500 to 300 to 500. And it will allow the doctor to be a doctor, and that's really appealing. You're going to be able to be an advocate. Actually, I've prepared 10 pages here, and I know I don't have time to develop all that, but there's 3 elements to what a physician tries to do, and that we're dedicated and trained to do, and that's advocacy, accessibility, and availability. All of those things are going to be massively impacted by the Obama Act, and in an egregious way. The good things about the Obamacare are offset by flaws that are mephitic, by representations that are mendacious, and it is going to be straddled to a Medicare program that is already crippled and wounded, and pull from that 500, I got a 700 billion pull. And then you mentioned the additional Medicare tax, which they've already earmarked not to go to Medicare, but to go to subsidize the overruns in the Obamacare. So, but going back, and you're most interested, of course, in Alaska, and what's going to happen to us here. And if you, I want you to know that the MDVIP has had several meetings with doctors in the community, and everybody's scratching their head. Now, I have turned them down. I will continue to turn them down, because I feel that patients at primary care associates, and I pointed out to them, already get VIP treatment. That we spend time with them, and we have access. We are available. We do a lot by phone. In fact, we do all of that phone work is not compensated. 5 years ago, our group started the process of opting out of Medicare. We were considered pariahs. We were, you know, really low in the social calendar here, and the reason why we did that is when a clinic, and it's been shown over and over in the lower 48, derives 19% or more of its revenues from the Medicare population, it will go bankrupt in 5 years. We chose not to take that course. We didn't want to go bankrupt. We really wanted to be able to serve our patients. And all along, understand that I don't know if anyone in this room has been as concerned and interested about Medicare as I have. I don't think you have. Because in 1964, I was a pretty successful debater. That topic was socialized medicine, 1964. It was presaging and anticipating the Medicare passage in 65. I've lived with it and advocated for my patients since then, and I know you don't think I'm a day over 65, but that wounds me sorely, because I got 4 months before I have to make the decision that my patients struggle with. Should I get A, B, you know, and what part of D, and how does this all work, and doesn't supplemental insurance really pay all the rest of the money that you don't get paid for your services? So this has an incredible effect. I believe, as a good debater from the old days, that we have to define our terms. It is not health care. That's not a compound word. It's medical care that we're talking about. Health is a state of soundness. Okay, and then we talk about body soundness. You have spiritual health and emotional health, psychic health, but it's soundness. Health is determined not by care. Health is determined by genetics, by your personal choices. And I'm not going to quibble with whether it's 40 or 45%, 50-50, and then maybe 5 or 10% by chance, which includes bad luck, societal situations. So work with me, and we'll say it's 45-45, genetics and personal choices. Now, I tell my patients pretty graphically, because I try to make an impression. Skip, my friend, and been a patient, but now a friend, and hopefully will stay my friend after this conversation. But, you know, my typical conversation, and he'll validate this, is that we all reach a level of fitness. The Olympics were wonderful. You see all these wonderfully fit people, but you realize when they interview the athletes, and when they're 50, 60, 70 years old, that the ravages of time, you know, will be honored. Okay, so we reach a level of fitness, and it's around 32, give or take a couple of years. Then we begin the slide down the razor blade of life. That's a metaphor that I really drill into people. Think of it. Sliding down a razor blade is never comfortable. So the slope of that slide is determined by those health parameters. The slope is determined 50% by your genetics, 50% by your personal choices. Now, I never mentioned in that where medical care came in. Medical care provides the breeches for your bottom on this slide down the razor blade of life. It slows the process, but it doesn't change the slope. It changes the rate at which you go down the slope, perhaps. But that depends on how steep a slope you have. All right? So we have to use the terms properly. I don't use health care. I use medical care, and I talk about health. And insurance, what does insurance have to do with health? It's a payment plan. First of all, it's a misnomer. Insurance is a contingent as a payment for a contingent liability. Guess what? As far as I know, everyone in this room gets to die. That's the only truth you're going to get from me today, and I tell that to my patients. Everything else is going to be probabilities. All right? N equals 1, which means statistically everyone dies. Well, insurance, when you buy fire insurance, you don't think your house is going to catch on fire. That's a contingent liability that actuarially is spread. Okay, so that creates a real disconnect. And so the Ponzi scheme, so to speak, of the younger paying the premiums for the older, it creates an issue. I can give you so many examples of what's going to happen.
But we're gonna jump.
All right,
we're gonna jump.
Sorry.
Because you hit on so many different aspects in the discussion here about the realities that you face as a practitioner, the decision that you had to make to not take Medicare eligible, the decision that you will be making as a Medicare eligible.
I want to qualify that, though, Senator, before we move on, as I know we should. We still see 98% of our patients over 65.
Good.
We contract with them independently. We provide $130,000 per month of uncompensated care. That's unsustainable in Alaska because we're not the only clinic that does that. As the population grows and we have grows older and we have more Medicare, we won't be able to sustain that. That's $1.7 million our clinics provide in uncompensated care, the majority of that to folks over 65. While we don't participate in the program known as Medicare, we do see our patients as they become over 60, as they
Which
go
is
over
an
65.
important point. Thank you for bringing that in. Skip, let me ask you, from your business perspective, I mentioned you've got 120 employees at certain times of the year, then during other times you drop back. Have you had an opportunity as an Alaska small business to assess what implementation of the Healthcare Act is going to mean to you in terms of providing for coverage for your employees?
Short answer, yes. Before I answer the question, though, I have to go back to Bruce.
Is he still your friend?
He's still my friend, and he's been my doc way before I lost my hair. If that gives you any indication of how long we've been friends, it's been over 30 years. And he's been a great doc for me. Has encouraged me immensely to do things that I probably should have taken his advice on years and years ago. However, this old body is just starting to wear out, and he now makes sense to me. So getting back to your question, yes, I mean, 10th and M, we started out, back 33 years ago with my wife and I and a butcher, and that's three employees. And now we do employ over 120, actually it's about 140 people throughout the season a year. That has demanded over the last 2 years that I think very seriously about this employer mandate. And quite honestly, my son has grown up in the business now, and that brings a whole nother dynamic into our business. And for years now, he's been developing himself to take over the business when I retire. This is a problem because, as you all know, with the employer mandate, I've got to keep that under 50 full-time equivalents, and that's next to impossible for us in our business. Now, the good thing is we do look at this seriously, and we have started again over the last 2 years to talk with our healthcare providers and our tax folks to see how we can work through this. I know we'll get into this later, but part of my scenario is seasonal employees. And because of the seasonal employees, there might be a chance for us to have a respite to this.
And just explaining, a seasonal employee under the terms of the Act is anyone who works less than 120 days per year.
Correct.
And so you've got, what, about half your employees that are seasonal?
Actually, no, 2/3. Actually, I employ about 140 people, and 120 of those are seasonal.
Okay.
Seasonal. And that presents a real dilemma. Fortunately, the fish take care of part of that problem because they don't really start until May and June. And for me to hire these people, I have to wait until the fish come to me. Thank God they end at a certain point in our summer season, and so I have kind of a spread that I can work with, and which is basically 90 days. Now, on both ends of that, I can play a little bit now. But my son, of course, wants to grow the business, and he says, Dad, we want to do cod, too. Well, that means October, November, January, February. Well, I'm sorry, son, you can't hire any more people. Not while I'm on watch, because I want my retirement. So he fights me daily on that issue, and that's going to be a real dilemma for us to figure out how we can take those seasonal employees and work them. I can't hire, if I hire 120, I can't hire 360 to eliminate the overtime, which could happen, or if I go into the rest of that over the 120 days, then that's the only choice I've got, is to hire new people.
But you under the law, you do have a choice. You can either provide for the required health care under the employer mandate if you have over 50, or you can pay the fine. Have you assessed that in terms of, I mean, is it a situation where it would actually be cheaper for you to just pay the fine on a per employee basis? Have you done that assessment?
I have, and when you get into the formulas used for what is an equivalent employee, it gets a little confusing, and I have to rely on my healthcare guys. But we have done that, and I don't know at this point what our real choices are going to be, because this act has not been fleshed out enough for me to make decisions that are going to either totally destroy the ability to do growth in my business, or figure out a way where I can get around some of the parts of the act. That's my biggest concern right now.
Let me ask you a question, Michael. This kind of ties in with the various taxes that will come into play. The one that I mentioned that I think will have a higher impact here in Alaska is this new investment income tax, the 3.8% tax. So if you sell a home, you will now be taxed a brand new tax, 3.8% on the sale of that. How do you feel that the implementation of this new tax will impact us within the market itself? Do you see a concern, perhaps a slowdown in sales, impact to the market, or how have you assessed what may be coming?
First off, it's something that the National Association of Realtors was highly opposed to, and in the original draft of the bill, we were able to kill that. And with the Budget Reconciliation Act, excuse me, that came after that, this provision was reintroduced and enacted. It is a 3.8% Medicare tax, is what they're calling it. And the biggest effect it has right now is that most people are afraid of it because they're ignorant of the mechanics of it. And like everything else in the bill, the mechanics are highly complicated. It will not affect all consumers, but it will affect single people with an AGI above, or adjusted gross income above $200,000, or a couple above $250,000. But there's so many vagaries with how this is written. I've read through it. The National Association of Realtors is highly fearful of it, and worse than that, at this point, the consumer believes that it's going to affect any and every home that they sell. They're either afraid to buy a home because they're not sure what this is going to do. There's a lot of people that are on the edge of retirement that are thinking, oh, maybe I better put my home on the market right now and fire sale it, because any equity that I have, if I take the 3.8% out of it, it's going to affect my retirement. It's going to affect my ability. You know, anytime that we see things like this, it was like the effects of the Dodd-Frank bill on real estate. The unintended consequences of the law is what we're more afraid of. And as you know from Dodd-Frank, we went from the Community Reinvestment Act to Dodd-Frank that put so many restrictions and so many fears in bankers that the lending criteria has become so tight that it's very difficult for people, even with good credit scores, to take advantage of these low interest rates. So the long and the short of it is, it is not intended or designed to have a direct impact on most consumers. However, it is casting a pall on the industry in itself. And if real estate does not recover, the economy will not recover. Real estate, residential real estate, accounts for $2.23 trillion in the economic activity. For every 2 homes that sell, a full-time employment situation is created. And for every home that sells, $65,000 of ancillary economic activity takes place each and every time. So if real estate does not recover, and it's on a slow, tepid recovery now, but if it doesn't recover strongly, the economy will never get back to where it needs to be.
Well, I think it's important. Can you mute that? This is very distracting. I'm trying to listen to. But what you point out is the uncertainties that we have within our policies that are at play right now, whether it's what may or may not happen with sequestration, whether what may or may not happen with our tax policies that we'll be dealing with later in the year, and now the rollout, the implementation of the healthcare law, and how this all intersects, I think is causing what I and others have described as almost an economic purgatory,
Right.
Which further compounds the issues that we're dealing with. Doctor, do we have enough providers here in this state to really address the needs of Alaskans? Is this act going to impact further our access to care? As we know, we've got some specialties that just we simply don't have the providers. We know that we're always looking for internists and general practitioners, those that are seeking care through Medicare. Do we have the providers that we will need?
We don't have, I mean, we have a doctor shortage and have had it for some time in Anchorage and in Alaska. We tried to address it in a number of ways. But, you know, when we talk numbers, you know, you rein me in appropriately, I get passionate about...
You do, that's a good thing.
I get passionate about value, okay? And the value is, you know, do we have enough gas pumps that will pump 90 octane? Absolutely. Is that the kind of kiosk medicine that you want? You know, you develop a relationship with your physician. They become an advocate. When I get a call from Philadelphia 6 months before a very popular rock star comes to town and says, you know, Dr. Kiesling, I want you to take care of me and my entourage. What does that tell you? It tells you that you want to connect with the doc who you trust, and he didn't know me from Adam. I knew him. But, and you want to have them advocate for you. And then you want them to have access to all that really is most relevant for their care, and then you want them to be available. All 3 aspects are absolutely in jeopardy for the Medicare patient. They are being displaced. So, you know, I said 98% of our patients who turn 65 stay with us. We work it out. We have a sliding scale. We do everything we can to continue that relationship. But 2% just get angry or they just want to do something different. So they go to another situation. They have to establish that trust. Now, I'm not going to dog the manger that say that, you know, these clinics don't serve a huge and important purpose. The Medicare clinic in Providence and the one on Ellsworth Highway, and then the neighborhood health. But they are being constrained. There are delays in getting appointments to them. And then one of them actually has a model that is antithetical to the medical home model, which is, you know, you come in, You know, and what happens with a person when they turn 65? Virtually all of them have at least one chronic medical problem and 4 to 5 medicines. When they're over 65, at least half of them will have 5 or 7 medical problems, and they'll be seeing about 10 docs sometimes, 8 to 10 docs. So if you go to a Medicare clinic, that medical care clinic has to be able to effectively advocate. And one of the clinics, you know, they have excellent practitioners there, but they're restrained by what they can do to advocate. So they have to tell that patient, pick a problem. I know you have 17 problems, but pick one. That's what we'll take care of today, and now you make another appointment. Well, you talk about unintended consequences. How easy is it for a person over 65 to mobilize, to get to their appointment? You know, you need to be able to sit down and work through these things. I spend an average of half an hour to 45 minutes with a patient, but my nurse and I spend another, in the patient over 65, we will spend, before their next appointment, another 2 or 3 hours working with them with their medications, compliance, making sure that things are working for them, and that's all non-billable events. And that's the value. And I am that is not a whine. It is a privilege to be able to do that. But economically, it's unsustainable. So the answer to your question is 9 out of 10 physicians. This is really sobering. Discourage their children from going into medicine. 50% of the care in Alaska is provided by docs over 50. And if Obamacare is implemented in its fullest form nationwide, I don't know how accurate it is for Alaska, are going to retire in the next 5 years. So we don't have to get parsed down too tightly with the figures to know that we're going to have a shortage of advocacy for sure. Yeah, on my radio program, I have 2 features. One is the uninvited third person in the room, that insurance or a government that says, no, you can't have that. And that's determining medical care. And the other one is the wall of shame. I, of course, plagiarized that from Jim Cramer. I've never had an original thought. Just don't know to whom to give credit. And this one is Jim Cramer. And it's, you know, where I will literally say, I'm trying to do this for my patient. It costs $99. It's going to tell me everything I need to know. But this clerk over here in this insurance says, I've got to run you through a treadmill. And I've got to do this, and that's going to be $2,000. So I put them on the wall of shame. The problem, and people think that docs are going to pull back from medicine because of cupidity. Okay, you spend 4 years in undergrad, 4 years in medical school, a minimum of 3 years in training. You're in your 30s, and now you've got $150,000 to $200,000 in debt, and you're going to get paid at primary care level, at the level of a middle manager. We went into medicine because we wanted to advocate and care for patients. We knew we were going to have a decent income. It's not cupidity that is going to cause docs and people to make a decision not to go into it. And I will not summarize the article, but I want you to read the article August 6th about what's going on in Massachusetts. It's called Romney Care 2.0, and you will see where this is headed, and you will see that that really pulls it together of why we're going to have a huge shortage of doctors. Other than that, I don't have an opinion.
Well, it's clear. There is much yet to be learned. I think we are still trying to understand the impact of this healthcare law, whether it's on the medical community, whether it's on small businesses, whether it's on the effect of the economy as a whole. I think we recognize that clearly it is an issue that will continue to compound our debt concerns. I have made the statement many times that whether you are a supporter of the health care law or an opponent of the health care law, the fact remains, certainly here in this state, we haven't seen increased access to care. We haven't seen the cost go down. I was visiting just yesterday on the Kenai Peninsula with a man who has been married for about 6 years. He's got a 2-year-old daughter. He and his wife would like to have another child. He is self-employed. They had a policy that was costing him $1,200 a year. That's now been increased to $1,600 a year. Their deductible per individual in the family is $7,500. they are in a situation, whereas he has said to me, he says, how do I tell my wife that we can't have another child because we can't afford the insurance? So as we talk about the health care law and as we see these pieces of it roll out, I continue to wait for the response that shows me that we have actually reduced the cost of care, that we have increased access, and we have made the situation better for people here at home and people around the country. I happen to believe that we need to take this cake that has been made and revisit it. How we are able to reduce our costs. I think we're a perfect example here in Alaska of a small market that doesn't get a lot of interest from the big companies that would provide for a level of insurance. We don't have pooling. We don't have, we've got limited pooling. We don't have the ability to purchase across state lines. We didn't touch tort reform and liability. I think that remains a big issue. But I also don't think that we dealt with the delivery of care and the fact that we are still in a process that pays for services as they come. And as you point out, Dr. Kiesling, pick one of your 17 ailments and let's focus on that instead of really assessing the delivery. There is clearly much to be done. I'm quite concerned about the impact on our economy and how we will, in a world of unintended consequences, perhaps make business judgment decisions that pull back on our jobs and job creation, that pull back on your ability to expand. So how we move forward is going to be critically important in these months to come. We've got to end here. I appreciate not only those of you who have joined us, those of you who are here, but also those that have participated online. My sense is that it's good discussion, but it raises more questions than perhaps we have resolved. I am going to depart quickly. I'm going to the funeral of a dear friend, Al Adams, Senator Adams, and otherwise I would have welcomed the opportunity to visit with you in the room to field further questions, but I think this may just be the beginning of many conversations that we have on healthcare, the costs and the impacts here in this state. And with that, I thank you all. Thank you very much. To the folks here and the press.